Hi everyone, I'm Farzan and we are from Group 17 consisting of me, Aida, Ong and Kamini. We'll be presenting about the malignant neoplasms of the oral mucosa. So let's begin with the learning outcomes, which are list the various malignant neoplasms affecting the oral mucosa and differentiate the histopathological features of malignant neoplasms affecting the oral mucosa. We have divided the malignant lesions based on site or origin, starting with epithelial origin, which has oral squamous cell carcinoma, rectus carcinoma, basal cell carcinoma, and melanoma. Then coming to lymph tissue, which has lymphoma. Next is soft tissue, which has Kaposi sarcoma, fibrosarcoma, malignant schwannoma, leiomyosarcoma, rhabdomyosarcoma, liposarcoma, and angiosarcoma. Next will be bone, which has osteosarcoma, chondrosarcoma, and Ewing sarcoma. Coming to salivary gland, which is mucoepidermoid carcinoma, polymorphous low-grade adenocarcinoma, carcinosarcoma, acinic cell carcinoma, and adenocystic carcinoma. Lastly, it is from the odontogenic origin, which is malignant ameloblastoma. Let's start with the epithelial origin. The first malignancy that I'll be talking about is oral squamous cell carcinoma, which is the most common and important oral malignancy. So it accounts for more than 90% of all oral malignancies. It has a very clinical presentation which can occur on the lip of mammalian, intraoral sites such as the tongue, floor of mouth, gingiva, palate, and even on the labial or buccal mucosa. Now moving on to histopathology, the main feature in every malignant lesion of epithelial origin is dysplastic features of epithelial cells, starting with enlarged nuclei and cells, large prominent nuclei, altered nuclear to cytoplasmic ratio, hyperchromatic nuclei, pleomorphic nuclei and cells, dyskeratosis, increased mitotic activity, abnormal mitotic figures, multinucleation of cells, bulbous or teardrop-shaped peterages, loss of polarity, keratin pulse, and loss of typical epithelial cell cohesiveness. You can use this diagram here to have a rough idea of how it looks like. Now to classify oral squamous cell carcinoma, we use the broadest classification, starting with the well-differentiated or grade 1, which has less than 25% of undifferentiated cells. Next is moderately differentiated or grade 2, which has less than 50% of undifferentiated cells. And lastly, poorly differentiated or grade 3, which has less than 75% of undifferentiated cells. For well-differentiated squamous cell carcinoma or grade 1, tumors that produce significant amounts of keratin and exhibit some features of maturation from basal cells to keratin are considered to be well-differentiated. You can also see epithelial iron, which is here. They have a similar resemblance to the original epithelial. Then keratin pearl formation, which is the circular figures here, and it has a whorl appearance. Next is increased mitotic activity and dysplastic epithelium invading the connective tissue. You can see here on the right side that the epithelial cells with the keratin pearls are invading into the connective tissue. Next, for moderately differentiated squamous cell carcinoma or grade 2, tumors that produce little or no keratin but in which the epithelium is still recognizable as stratified squamous. Despite its significant deviation from normal, it is still regarded as moderately differentiated. It also has increased in number of pleomorphic cells, but still they can be identified as squamous epithelium. It has increased nucleopleomorphism and increased mitotic activity. For poorly differentiated squamous cell carcinoma or grade 3, tumors that produce no keratin, bear little resemblance to stratified squamous epithelium, exhibit a significant lack of normal architectural pattern and cohesiveness of cells, and exhibit extensive cellular abnormalities are designated as poorly differentiated. It has also abnormal mitotic figures and increased pleomorphism. You can see in the diagram on the right side here that it has very little resemblance to a normal stratified squamous epithelium. So oral squamous cell carcinoma also have additional features which are perineural invasion, vascular invasion, angiogenesis, and desmoplasia. The next oral malignancy is basal cell carcinoma. It appears as a rodent ulcer with the rolled borders on the sun-exposed skin. You can see here from the diagram is a picture of a man with a rodent ulcer on the nose. For histopathology, it is a uniform ovoid dark staining basal cell with medium-sized nuclei and little cytoplasm. That's why in the diagram here you can see that the cells are quite dark in color because they have less cytoplasm. and the cells are arranged in a well-demarcated island which appear to arise from the basal cell layer of the overlying epidermis and invading the underlying connective tissue. You can see in the diagram here that the cells from the epithelium are invading the connective tissue. Next, the epithelial island typically demonstrate palisading of the peripheral cells and central area composed of uniform basal cells. This is what you can see in the diagram here. And also artifactual retraction is seen between the epithelial island and the connective tissue. Next, coming to verrucous carcinoma, which appears as a thick white plaque with exophytic papillary growth, which can occur on the gingiva, alveolar mucosa, buccal mucosa, hard palate, and floor of the mouth. So histopathologically, the surface of the tumor is usually papillary and covered with a thick parakeratin layer. And then the deep crypts containing plugs of parakeratin usually occurs between the elongated surface projections, which is also known as keratin plugging. You can see here. Then the epithelium is dysplastic, but seldom exhibit severe dysplastic features. It has also broad bulbous rete-ridges. You can see here, they are quite broad. Then there is intense chronic inflammatory cells infiltrate, which is often present in the underlying connective tissue. So this is another histopath diagram for verrucous carcinoma. You can see the thick keratin layer with keratin plugging, then a broad rete-ridges, and the chronic inflammatory cell infiltrate in the connective tissue. The next malignant neoplasm is melanoma. It is actually melanocytic in origin, but it also occurs in the epithelium. It rarely occurs in the oral mucosa, and it appears as dark brown, black, or bluish black. There are four main types of melanoma, which is superficial spreading melanoma, nodular melanoma, lentigo-malignant melanoma, and acral-lentiginous melanoma. So for histopathology, it appears as atypical melanocytes which are enlarged with varying degrees of nuclear pleomorphism and hyperchromatism. You can see here the dark cells here are the atypical melanocytes. It is usually seen at the epithelial and connective tissue junction, which is same as the diagram here. There's two growth phase for melanoma, which is radial growth phase and vertical growth phase. A radial growth phase is characterized by the spread of atypical melanocytes along the basilar portion of the epidermis. Then there is pagetoid spread, which is single tumor cells infiltrating into the upper layers of the surface epithelium. This is seen in the superficial spreading melanoma. Then for vertical growth phase, it is a malignant melanocytes invading into the connective tissue, as you can see here. And there's also atypical spindle-shaped melanocytes. It's the atypical spindle shape. These two features here are common in nodular melanoma. Now coming to the lymph tissue. So lymphoma is a cancer in the lymphatic system which occur on the lymph nodes, or it can also manifest in the oral cavity as extranodal sites. So there are different types of lymphoma, which is Hodgkin lymphoma, non-Hodgkin lymphoma, and Burkitt lymphoma. So starting with the histopath of Hodgkin lymphoma, it appears as atypical lymphoid tissue known as Reed-Sternberg cells. You can see here. It is binucleated or multinucleated and appears as owl eyes. Next is non-Hodgkin lymphoma. It appears as diffuse infiltration of the subepithelial connective tissue by lymphoma. You can see the dark stained cells here are the lymphoid cells. Lesional cells of lymphoma consisting of a population of poorly differentiated cells of the lymphocytic series with minimal cytoplasm. So on the right side here is a closer look of the lymphocytic cells with minimal cytoplasm, therefore it appears dark. Now coming to Burkitt lymphoma, it appears as the classic starry sky appearance, a pattern caused by interspersed histiocytic cells with abundant cytoplasm known as stars, which is the lightly stained cells here, and set against a background of malignant darkly stained lymphoma cells, which is a night sky, which is the dark stains surrounding the histiocytic cells. Now we're moving on to the soft tissue origin. The first soft tissue oral malignancy I'll be explaining is Kaposi sarcoma. It is a rare vascular tumor which rarely occurs in oral cavity, but if it occurs in oral cavity, it appears on the palate. As you can see on the right side, It is red in color due to its vascularity. So it typically involves three stages, which is a patch stage, plaque stage, and nodular stage. Let's start with patch stage. There is a proliferation of miniature vessels results in irregular jagged vascular network that surrounds the pre-existing vessels. Normal structures like hair follicle may protrude into the new vessel. It is known as a promontory sign. Lesional endothelial cells have a bland appearance, may be associated with scattered lymphocytes and plasma cells. Next is the plaque stage, which demonstrated further proliferation of the vascular channels and a significant increase in spindle cell component. Lastly is nodular stage, which is spindle cells increase to form a nodular tumor-like mass that resemble fibrosarcoma or other spindle cell sarcomas. Numerous extravasated RBCs are present along with slit-like vascular spaces. So that's all from me. So I'll pass on to Ida for the next lesions.
Hi, I'm Ida, and now I'll be talking about fibrosarcoma. Clinically, fibrosarcomas often present as slow-growing masses that may reach considerable size before they produce pain. They can develop at any age and occur anywhere in the head and neck region. Now moving on to the histopath, it varies in histologic grade. There are three forms which are well-differentiated, intermediate-grade tumor, and high-grade lesions. In the well-differentiated form, there are multiple plump fibroblasts with pale eosinophilic cytoplasm, deeply staining spindle nuclei with tapered ends. The malignant cells are dispersed in a rich collagen background, and there is minimal pleomorphism and low mitotic index. In the intermediate-grade tumor, there is typical herringbone arrangement of tumor cells, which are characterized by parallel sheets of cells arranged in intertwining whorls. It is quite cellular with slight degree of cellular pleomorphism. There are also moderate amounts of mature collagen that may be produced, perhaps with areas of hyalinization. In high-grade lesions, it appears very cellular with marked cellular atypia and mitotic activity. The matrix is sparse, and multinucleated giant cells are rarely seen. There are no malignant osteoid formation that should be present, and the cells are extremely anaplastic and pleomorphic with bizarre nuclei. Now moving on to malignant schwannoma, it is also known as malignant peripheral nerve sheath tumor or neurofibrosarcoma. Nearly half the cases of malignant schwannoma occurs in patients with neurofibromatosis type 1. It is most commonly seen in young adults, and the tumor is an enlarging mass that sometimes exhibits rapid growth. It is associated with pain or a nerve deficit. Oral tumors may occur anywhere, but the most common sites are the mandible, lips, and buccal mucosa. Histologically, it resembles fibrosarcoma overall, but these atypical spindle-shaped cells are more irregular in shape with wavy or comma-shaped nuclei. Less cellular myxoid areas also may be present. Next is leiomyosarcoma. It is a malignant neoplasm of smooth muscle differentiation. In general, it is most commonly seen in middle-aged and older adults. However, tumors in the oral and maxillofacial region occur over a wide age range without a predilection for any age group. They have been reported at various sites, but half of all oral cases occur in the jawbones. The clinical appearance is non-specific. There is usually an enlarging mass that may or may not be painful. Secondary ulceration of the mucosal surface may occur. Histologically, fascicles of spindle-shaped cells with abundant eosinophilic cytoplasm and blunt-ended cigar-shaped nuclei are seen. It may be primarily composed of rounded epithelioid cells that have either eosinophilic or clear cytoplasm. The degree of pleomorphism varies from one tumor to the next, but smooth muscle tumors with the presence of 5 or more mitoses per 10 high power fields should be considered malignant. Next is rhabdomyosarcoma. It primarily occurs during the first decade of life, but may also occur in teenagers and young adults. It is rare in people older than 45 years, and more than half the cases occur in males. There are different types of rhabdomyosarcomas, which are embryonal, alveolar, and pleomorphic. The tumor is most often a painless infiltrative mass that may grow rapidly. The palate is the most frequent intraoral site, and some lesions may appear to arise in the maxillary sinus and break through into the oral cavity. Some embryonal rhabdomyosarcomas that arise within a cavity, such as the oropharynx, demonstrate an exophytic polypoid growth pattern that resembles a cluster of grapes. The term botyroid or grape-like rhabdomyosarcoma has been used for these lesions. Now moving on to the histology of the embryonal type of rhabdomyosarcoma. Poorly differentiated examples consist of small round or oval cells with hypochromatic nuclei and indistinct cytoplasm. Alternating hypercellular and myxoid zones may be seen. Better differentiated lesions show round to ovoid rhabdomyoblast with distinctly eosinophilic cytoplasm and fibrillar material around the nucleus. The botyroid subtype of embryonal rhabdomyosarcoma is sparsely cellular and has a pronounced myxoid stroma. There is increased cellularity, or a so-called cambium layer, which is usually seen just beneath the mucosal surface. The cellular type of rhabdomyosarcoma has a classic and a solid variant. The classic variant is characterized by aggregates of poorly differentiated round to oval cells separated by a fibrous septa. Cells demonstrate a central loss of cohesiveness, which results in an alveolar pattern. Peripheral cells of these aggregates adhere to the septal walls in a single layer. The central cells appear to float freely within the alveolar spaces. Mitosis are common, and multinucleated giant cells also may be seen. The solid variant of alveolar rhabdomyosarcoma demonstrates cellular fields of small round basophilic cells without fibrovascular septa. Next, I'll be talking about liposarcomas. Liposarcomas are seen primarily in adults. The mean age for head and neck tumors is 57 years. The tumor is typically a soft, slow-growing, ill-defined mass that may appear normal in color or yellow. Pain or tenderness is uncommon. When present, it is usually a late future. The neck is the most common site for liposarcomas of the head and neck region. The most frequent intraoral locations are the tongue and cheek. Histologically, there are four forms. The most common one is the well-differentiated liposarcoma, or the atypical lipomaceous tumor. The tumors resemble benign lipomas, but demonstrate scattered lipoblasts and atypical hypochromatic stromal cells. The myxoid round cell liposarcoma demonstrates proliferating lipoblast within a myxoid stroma that contains a rich capillary network. The round cell liposarcoma is a more aggressive form of myxoid liposarcoma with less differentiated rounded cells. The pleomorphic liposarcoma exhibits cellular pleomorphism and bizarre giant cells. Lastly, dedifferentiated liposarcoma is characterized by the combination of well-differentiated liposarcoma with poorly differentiated, non-lipogenic sarcomaceous changes. Now I'll be passing it to Ong to discuss about the further lesions.
Thank you, Ida. So now I would like to continue the seminar with angiosarcoma. So angiosarcoma is defined as a rare malignancy of vascular endothelium which may arise from either the blood or lymphatic vessels. It usually occurs in the head and neck region, and oral lesions are usually quite rare. Angiosarcoma is categorized by an infiltrative proliferation of endothelium-lined blood vessels that form an anastomosing network. Endothelial cells usually appear hyperchromatic and atypical, and they often tend to pile up within the vascular lumina. There is also increase in mitotic activity, and immunohistochemical studies usually shows the tumor cells to be positive for CD31 and factor VIII related antigen in most cases. whereas CD34 positive is observed less consistently. So in histopathological finding, you can see irregular infiltrative growth pattern with anastomotic blood capillaries, okay, containing intraluminal spindle-shaped tumor cells, which can be seen here. And there are also multi-layering of epithelioid endothelial cells with extravasated red blood cells. There are also malignant endothelial cells arranging themselves to form lumen, okay, within the existing vascular lamina. So in this picture, okay, you can see endothelial cells, which I'm circling it now, okay. This shows nuclear polymorphism with prominent and multiple nuclei. Okay, in this picture, you can see area of necrosis. There are intense trauma inflammation with the predominance of eosinophils, which present along with some extravasated red blood cells. So now let's continue with bone malignancy. So the first bone malignancy is osteosarcoma. So osteosarcoma is defined as the malignancy of mesenchymal cells to produce osteoid or immature bone. So oral lesions are usually pain and swelling, and you can see tumor cells produce chondroid and fibrous connective tissue. So the amount of matrix produced may vary considerable depending on the relative amount of osteoid, cartilage, or collagen produced by the tumor. So they are classified as conventional osteosarcoma, which known as the osteoblastic subtype, chondroblastic subtype, and fibroblastic subtype. Low-grade osteosarcomas usually show minimal cellular atypia and abundant bone formation. When we move on to histopathological features of osteoblastic osteosarcoma, you can see atypical neoplastic osteoblasts that exhibit variation in size and shape, which can be seen here. They are usually deeply stained nuclei arranged in the disordered fashion about the trabeculae of the bone. Irregular pattern of new tumor, osteoid, and bone formation are also usually seen. When we move on to fibroblastic osteosarcoma, you can see varying degree of proliferation of anaplastic fibroblasts with absence of tumor osteoid. Occasional area of neoplastic myxomatous tissue and cartilage can also be seen. In chondroblastic osteosarcoma, you can see chondroid matrix predominantly here, okay, and also partly here, okay. There are also osteoid between spindle cells or in the center of chondroid lobules. So the next bone malignancy is chondrosarcoma. So chondrosarcoma is defined as a malignant neoplasm in which the tumor cells form cartilage but not bone cells. It has a mean age of 51 years old with slightly male predilection. The common clinical finding shows painless swelling, and the maxillary tumor usually occurs at the anterior region, while the mandibular tumor occurs at the posterior region. Chondrosarcoma usually composed of cartilage showing varying degree of maturation and cellularity with lobular growth pattern. The central of the lobule usually demonstrate the greatest degree of maturation, whereas peripheral areas exhibit immature cartilage and mesenchymal tissue consisting round or spindle-shaped cells. Calcification or ossification may occur in chondroid matrix, and the tumor is usually richly cellular with pleomorphic and hyperchromatic chondrocytes, many of which have multiple nuclei. Next, let's move on to variants of chondrosarcoma. There are 4 variants. The first one is clear cell chondrosarcoma. It shows low-grade variant exhibiting cells with abundant clear cytoplasm. This variant may be difficult to differentiate from metastatic clear cell carcinoma. The second variant is dedifferentiated chondrosarcoma. It has high-grade variant that shows an admixture of well-differentiated chondrosarcoma and high-grade sarcoma. This variant is rare in the jaw. The next one is myxoid chondrosarcoma. It's classically described as a soft tissue tumor, although intraosseous lesions are possible. This variant is characterized by a proliferation of cells with clear, vacuolated, or eosinophilic cytoplasm within a background of mucoid material. The last one is the mesenchymal chondrosarcoma. It has 2 distinct elements. The first one is well-differentiated cartilaginous nodules, and the second one is the sheet of small undifferentiated spindle of round cell. So when we come to histopathological findings, you can see presence of increased proliferation of chondrocyte within the lacunae with increased nuclear atypia. You can also see nuclear hyperchromatism in this arrow here, and cellular atypia with binucleated chondrocyte can also be seen here. Okay, when move on to the right picture, you can see large abnormal chondrocyte exhibiting nuclear pleomorphism and also cellular pleomorphism here. So let's move on with the third bone malignancy, which is the Ewing sarcoma. So Ewing sarcoma usually shows broad sheets of small mononucleus round cells with well-delineated nuclear outlines and ill-defined cellular borders. It is variable in size, and the tumor cells are separated by fibrovascular septa, creating a lobular pattern. Ewing sarcoma shows extensive necrosis and hemorrhage. Okay, so in this picture, you can see rapid growth and also ulcerated tumor at the right mandible. So coming to the histopathological features, you can see mitotic figures, and the cells are usually positive for glycogen and diastase resistant. You can also see geographic necrosis with perivascular sparing. Okay, in this picture show uniform and small cells with finely dispersed chromatin and small nuclei. So let's move on with the salivary gland malignancy. So the first salivary gland malignancy is mucoepidermoid carcinoma. It consists of mucous cells, squamous or epidermoid cells, or intermediate cells. Mucous cells are vary in shape but contain abundant foamy cytoplasm that stains positively with mucin stain. Epidermoid cells are categorized by squamoid features, often demonstrating a polygonal shape, intercellular bridges, and keratinization, while the intermediate cells consist of both mucous and epidermoid cells, and it appears from small basaloid cells to slightly larger ovoid cells with scanty pale eosinophilic cytoplasm. Mucoepidermoid carcinoma is the most commonly found salivary gland malignancy and usually seen in 2nd to 7th decade in life. It's most commonly seen in parotid gland and usually appears as asymptomatic swelling, and the patient usually aware of the lesion for a long period of time before approaching the physician. So now let's come to the grading of mucoepidermoid carcinoma. Mucoepidermoid carcinoma has 3 grades, which is the low grade, high grade, and the intermediate grade. For the low grade, the tumor usually shows prominent cyst formation with minimal cellular atypia and a relatively high proportion of mucous cells. While in the higher grade, it consists of solid island of squamous or epidermoid cells, which is the most cells seen in this grade, and also intermediate cells, which shows pleomorphism and mitotic activity. While the mucus producing cell shows the least number of cells in this grade, and the tumor sometimes can be difficult to distinguish from squamous cell carcinoma. While in the intermediate grade, you can see features that falls between those of the low grade and high grade neoplasms. All 3 major cells, which is the mucous cell, epidermoid cell, and also the intermediate cells, are seen here, but only the intermediate cells are usually predominant in this grade. So that's all for my part today, and I would like to pass the floor to Kamini. Thank you.
Hi everyone, I'm Kamini and now I'll continue talking on polymorphous low-grade adenocarcinoma. So, polymorphous low-grade adenocarcinoma usually occurs on the hard palate or soft palate, and it's more common in older adults and females. It is usually a painless mass with slow growth. Sometimes it's also associated with bleeding or discomfort. Now, coming to the histopath of polymorphous low-grade adenocarcinoma. The tumor cells usually have a deceptively uniform appearance. They are round to polygonal in shape, with indistinct cell borders and pale to eosinophilic cytoplasm. The nuclei may be round, ovoid, or spindle-shaped. The cells may grow in a solid pattern or form cords, ducts, or larger cystic space. In some tumors, a cribriform pattern can be produced that mimics adenoid cystic carcinoma. As you can see, the picture on the right shows the cribriform arrangement of cells with pale nuclei staining. At low power, the tumor sometimes appears well circumscribed. However, the peripheral cells are usually infiltrative, invading the adjacent tissue in a single file fashion. Extension into underlying bone or skeletal muscle may be observed. The stroma is often mucoid in nature, or it may demonstrate hyalinization. Perineural invasion is common, as you can see on the picture on the right below. The picture on the top right shows the pale staining cells that infiltrate as single file cords. Next, I'll be talking about carcinosarcoma. Carcinosarcoma is a very rare tumor. In most of the cases are usually seen in the parotid gland, but it may also be seen in submandibular gland and minor salivary glands. The histopath of carcinosarcoma. The carcinosarcoma is a biphasic tumor which demonstrates both carcinomatous and sarcomatous areas. The epithelial component usually consists of a poorly differentiated adenocarcinoma or an undifferentiated carcinoma. Coming to the sarcomatous portion, the sarcomatous portion often predominates the tumor and it's usually in the form of chondrosarcoma, but it may also show characteristics of osteosarcoma, fibrosarcoma, liposarcoma, rhabdomyosarcoma, or malignant fibrous histiocytoma. Some lesions have evidence of an origin from a benign mixed tumor. Next, now I'll be talking about acinic cell carcinoma. Acinic cell carcinoma is basically a salivary gland malignancy with cells that show serous acina differentiation. About 90% of acinic cell carcinoma occurs in the parotid gland. This tumor occurs over a broad age range and it usually appears as a slow-growing mass. Acinic cell carcinoma is often well circumscribed and sometimes it may even appear encapsulated. However, some tumors exhibit an infiltrative growth pattern. The most characteristic cell is the one with features of the serous acina cell with abundant granular basophilic cytoplasm and a round, darkly stained eccentric nucleus. These cells are fairly uniform in appearance and mitotic activity here is uncommon. Other cells may resemble intercalated duct cells and some tumors also have cells with a clear vacuolated cytoplasm. On rare occasions, the tumor may demonstrate high-grade features which includes pleomorphism, increased mitotic activity, and necrosis. In acinic cell carcinoma, there are several growth patterns. There are 4 types of growth patterns, which include solid variety, microcystic variety, papillary cystic variety, and follicular variety. The solid variety consists of numerous well-differentiated acina cells arranged in a pattern that resembles normal parotid gland tissue. In the microcystic variety, multiple small cystic spaces are created that may contain some mucinous or eosinophilic material. In papillary cystic variety, larger cystic areas are formed that are lined by epithelium having papillary projections into the cystic spaces. And lastly, the follicular variety has an appearance which is similar to that of the thyroid tissue. A lymphoid infiltrate, sometimes with a germinal center formation, is not unusual. These two pictures shows acinic cell carcinoma. The first picture on the left shows sheets of granular basophilic serous acina cells, whereas the picture on the right shows the high power view of serous cells with basophilic granular cytoplasm. Adenoid cystic carcinoma. Adenoid cystic carcinoma is one of the more common salivary malignancies. Adenoid cystic carcinoma can occur in any salivary gland site, and palate is the most common site for the minor gland tumor. This lesion is common in middle-aged adults. It usually appears as a slow-growing mass. In adenoid cystic carcinoma, pain is a common and important finding. Occasionally occurs early in the course of the disease before there is a noticeable swelling. Adenoid cystic carcinoma is a biphasic salivary gland tumor. It's composed of ductal and myoepithelial cells. They are arranged and they produce a pattern of cribriform, tubular, and solid. In the cribriform pattern, it consists of islands of basaloid epithelial cells that contain multiple cylindrical, cyst-like spaces resembling Swiss cheese. It's also composed of predominantly myoepithelial cells with myxoid or hyalinized globules. Scattered ductal elements may also be seen. In the tubular pattern, simple tubules composed of inner ductal and outer myoepithelial cells are seen. Coming to the solid pattern, it is composed of sheets of basaloid cells, cellular pleomorphism, mitotic activity, focal necrosis in the center of tumor islands may be observed, and perineural invasion is also frequent. The first picture shows cribriform pattern which is composed of predominantly myoepithelial cells with hyalinized or myxoid globules. Scattered ductal elements may also be present. The second picture shows tubular pattern which is composed of inner ductal and outer myoepithelial cells, and the ductal cells are cuboidal with eosinophilic cytoplasm. The myoepithelial cells are angulated and basaloid. The first picture here shows tumor cells forming solid sheets and nests, and the second picture shows myoepithelial cells may contain abundant clear cytoplasm, which resembles myoepithelial cells seen in epithelial myoepithelial carcinoma. Now, I'll be talking on malignancies of odontogenic origin. Under odontogenic origin, the first malignancy is amyloblastic carcinoma. Amyloblastic carcinoma tends to develop later in life, with the mean age at diagnosis typically being in the sixth decade of life. Amyloblastic carcinoma affects men more than women. The histopath of amyloblastic carcinoma. Metastatic deposit or primary tumor shows the microscopic pattern of amyloblastoma in addition to cytologic features of malignancy. This includes an increased nuclear cytoplasmic ratio, nuclear hyperchromatism, and also the presence of mitosis. Necrosis in tumor islands and area of dystrophic calcification may also be present. Next malignancy under odontogenic origin is malignant amyloblastoma. Malignant amyloblastoma. The frequency of malignant behavior in amyloblastoma is difficult to determine, but probably occurs in far less than 1% of all the amyloblastomas. The term malignant amyloblastoma is used for a tumor that shows histopathologic features of amyloblastoma, both in primary tumor and metastatic deposits. Malignant amyloblastoma is usually seen in patients with the age range of 6 to 61 years old, and it does not have any sex predilection. The histopath of malignant amyloblastoma. With malignant amyloblastoma, the primary jaw tumor and the metastatic deposit shows no microscopic features that differ from those of the amyloblastoma with a completely benign local cause. These are our references. That's all from us. Thank you.